Welcome to TCCC-Plus Day 2, Module 4, Airway. This module teaches simple airway management and why airways fail over time. Airway compromise is a silent killer, easy to miss early, and it may get worse over time. After hemorrhage, it is the second leading cause of potentially survivable death on the battlefield. The bad news is that it can be difficult to catch, as they usually don't make a lot of noise, but just go quiet. The good news is that simple fixes usually work, because most battlefield airway trouble is about position, not about an injured windpipe. For the airway, asking what is getting better or worse and what is different since last time may catch the slow obstruction before it closes. Reassess after movement, after any change, on a schedule, after interventions and at handovers. When assessing an airway, ask three things. Is it open? Can the casualty protect it themselves? Will it stay open? Awake and talking in a normal voice means the airway is open right now. Snoring, gurgling, I cannot breathe, facial trauma, blood or debris, that is a problem. The signs to know about airway reassessment include the following: snoring or gurgling, choking, a hoarse or absent voice, altered mental status, facial or neck trauma, and visible debris into mouth and nose. I cannot repeat this enough. Almost all airways in combat casualties can be protected with simple means. Positioning comes first, always. And here is the counterintuitive part. A casualty with a smashed face will often protect their own airway better than you can, so let them sit up and lean forward, and let the blood drain out rather than back. Do not force a casualty to lie down. A manual jaw thrust is only a fallback. The sitting position, or recovery position if they are unconscious but breathing, does the work here, especially in PFC where this may last a while. If debris in the mouth, clear only what you can see, never a blind finger sweep if you want to keep all your fingers, and avoid pushing stuff further down or trigger vomiting. This illustrates once again position first because it is the highest value airway move you have. Sit up and lean forward to drain, recovery position if unconscious. A chin lift or jaw thrust can help, but positioning usually does more and it frees your hands. The only airway adjunct we teach at this level is the NPA, the nasopharyngeal airway. Simple, effective, well tolerated, small and easy to pack, it is a very useful but not a definitive airway, especially useful in reduced consciousness. However, we should avoid it in casualties with severe facial trauma or a suspected skull base fracture, and stop if you meet resistance. It is not taught, but only demonstrated in the in-person section.
Костя, терпи. Трубка може впиратися.
Тих. Нормально. Нормально.
Ленька потім дасть.
Все.
Якщо йому хочеться кашлять, пускай кашляє.
Да.
Треба викашлювати.
Все.
Це не мучте,
Це не
Допустим,
все.
виймайте тут нафіг.
Це лише
Ні,
перше
все,
препятствие. Ні, це
Ні.
якраз перше
Це
препятствие.
воно ще далі йде, бо вона маєш до упора йти.
все, тихо.
Ну що ти? Помаленьку. Може він кайфує лежить. Я вам кажу.
Не йде?
Що? Закладись.
Все, добре. Трубка не йде, добре. Тепер чуть-чуть
Не
підтягни.
трогай.
Це сам запихає.
Не трогай. Це
Пішла.
майстер-клас.
Да, ну.
Це якщо без
Це вже вона
сознання.
пішла, да.
The instructions make it look simple, though in reality this is not always the case. To place the MPA, measure from the tip of the nose to the earlobe for size and lubricate the MPA. Then orient and insert the MPA. Guide the bevel towards the septum, inserting it into the nostril at a 90-degree angle to the face, not upwards. Advance the MPA until the flange is flush with the nostril. Now, this is why this is a PFC problem. Again, the airway may worsen over time without the casualty necessarily making much of a fuss about it. Over hours, swelling increases, consciousness drops, blood and vomit pool, and the person looking after the airway gets tired too. So we reassess after movement, after any change, on a schedule, after interventions, and at handovers. Your main job is to recognise the problem and use positioning and NPAs to help out. If this isn't enough, escalate to higher levels of care if possible. Some things are definitely out of scope for non-medics, including intubation, surgical airways, and sedation. There is a hard reason this sits above you. Casualties who need an advanced airway placed forward tend to be the most badly injured, undergo the most interventions, and have the worst survival. And the procedures themselves are unreliable in the field, even in the hands of experienced providers. Recognize the problem, do the positional fix you can do well, consider placing an MPA, and escalate. Let's recap. Let them sit, positioning is king, assess and reassess according to the 5 times for reassessment and 5 questions, as well as the specifics for airway PFC. And remember, an airway may worsen over time. Thanks for watching Module 4 of the TCCC-Plus course, Day 2, Airway. Next up is Module 5, Hypothermia.